Hello, my name is Nicholas Levin. I'm an emergency medicine resident at the University of Utah. I'll be giving a presentation on acute coronary syndromes. To begin, I like to think of ACS as a spectrum of conditions compatible with acute myocardial ischemia and/or infarction that are usually due to an abrupt reduction in coronary blood flow. As you can see here, on one end of the spectrum, we have unstable angina. In the middle part, non-ST elevation myocardial infarction, or NSTEMIs. And then the other side of the spectrum, we have ST elevation myocardial infarction. By definition, the biomarkers are normal in unstable angina, whereas your troponins will be elevated in both NSTEMI and STEMI. And then EKG do not meet STEMI criteria in both unstable angina and NSTEMI, whereas they do in STEMI. An important note on unstable angina: while this is a small but significant proportion of our patients, typically just less than 4%, it is important to think of unstable angina measured against a patient's usual pattern of stable angina, which is most commonly classified according to the New York Heart Association's functional classification of angina, and that any new onset angina should be considered unstable in the first instance. In regards to the epidemiology of acute coronary syndromes, the Global Burden Disease Study in 2013 estimated that 17.3 million deaths worldwide in 2013 were related to cardiovascular disease. That's an increase of 41% since 1990. In Vietnam, in particular, if you look on the graph on the right, that is data from the Institute of Health Metrics at the University of Washington. As far as accountable deaths, 11% of which are accountable to ischemic heart disease in the country of Vietnam. In the United States, this is important to think about as we have 8 to 10 million patients complaining of chest pain presenting to the emergency departments annually. What that breaks down to is a large patient population that we need to figure out whether or not they have acute coronary syndrome or chest pain for other reasons. And among those, it is estimated that there is a man or woman suffering from an acute MI about every 42 seconds in the United States itself. As far as gender differences in acute coronary syndrome, generally speaking, men are your more classical presentations and have central chest pain, whereas women have more atypical findings. They tend to report fatigue, dyspnea, ingestion, nausea, vomiting, palpitations, and weakness. They are also more likely to delay presentation, and as far as the treatment side of things, they're less likely to be treated by guideline-directed therapies, have cardiac catheterization, and are less likely to receive timely reperfusion. So something very important to think about is a higher threshold of suspicion in women with atypical symptoms. In regards to risk of ACS, depending on what the chief complaint is, generally speaking, you have a decreased likelihood of acute coronary syndromes if the chest pain is described as pleuritic, or it's positional, or if it's described as sharp or stabbing. And again, it's also, if it's reproducible with palpation, it's less likely to be acute coronary syndrome. Alternatively, chest pain is more likely to be related to acute coronary syndrome if it is radiating to both arms, or if it's radiating to the right arm, and then lastly, if it's radiating to the left arm. Additionally, if it's associated with diaphoresis, nausea, vomiting, exertion, again, most likely to be acute coronary syndrome. Something to think and keep in the back of your pocket. In regards to the etiology and pathogenesis of acute coronary syndromes, they're typically broke down to 5 different etiologies of why someone might have a myocardial infarction. Typically, we think of type 1. This is our spontaneous myocardial infarction. It's an atherosclerotic plaque that rupture and intraluminal thrombus in one or more of the coronary arteries. Type 2 is a myocardial infarction secondary to ischemic imbalance. This is conditions other than coronary artery disease that contribute to an imbalance between myocardial oxygen supply and or demand. So that's our demand ischemias. Type 3 is cardiac death secondary to the myocardial infarction itself. This is a patient who suffers cardiac death with symptoms suggestive of myocardial ischemia without elevated biomarkers. Type 4 is myocardial infarction related to revascular procedures. There's a subtype 4A, which is related to PCI, and then 4B, which is related to stent thrombosis, and then type 5 is related to Cabot's procedures. When you think about acute coronary syndrome, you have to also maintain a very broad differential diagnosis. I like to think of these as broken into a differential diagnosis as critical versus emergent versus non-emergent. Briefly, to go over the most critical things you also must think about is aortic dissection, cardiac tamponade, pulmonary embolus, tension pneumothorax, esophageal perforations, and then that's supposed to say coronary artery dissections. And then also think about your emergent. That includes many of your itises, so your pericarditis, myocarditis, mediastinitis, pancreatitis. And then finally, more frequently, we'll see ACS, or rather patients presenting with chest pain that's related to non-emergent reasons such as GERD or panic attacks. But again, think of all these things when someone presents with chest pain. In regards to making a diagnosis of acute coronary syndrome, it really depends on four, I will say, different things you need to do. First and foremost is history, but then also EKGs, cardiac enzymes, and then the bedside ultrasound. When you have old EKGs, use them, compare to your current. A lot of people walk around with abnormal EKGs at baseline, and to know if something's new, it is important to have old EKGs available. Repeating and doing serial EKGs will help increase your sensitivity in somebody who has new onset chest pain that is evolving. And additionally, when you're looking at any EKG, you want to look for your ST segment elevations, look for those hyperacute T waves, as well as your ST set depression in reciprocal leads. And we'll go over some EKGs here shortly. And then later, we'll also talk about ACS risk stratification with our heart score and heart pathway. When you think about acute coronary syndrome anatomy, this goes back to our basic medical science as far as EKG placement and the anatomical locations of the electrical distribution of blood flow throughout electrical and vascular blood flow throughout the heart. So think about your leads and your precordial leads and where they correlate to your heart. I think this needs to go hand in hand at this point with our ultrasound findings, particularly in the peristernal short axis, as that distribution, as laid out here on the diagram on the right, helps us find kinetic and regional wall abnormalities indicative of myocardial infarction. So whenever you think of EKG, think about where your leads are located in relation to the heart, and then be quick to also use a bedside ultrasound to also correlate those same findings to where you might expect to see regional wall motion abnormalities. In conjunction, these two can really up your sensitivity and specificity for a timely diagnosis of acute coronary syndrome. Specifically, there's a pretty landmark paper that came out in 1991 that found that if you looked at patients presenting with chest pain, and they looked at 180 different patients in the state of in North Carolina, they found that if you use bedside ultrasound in conjunction, you had a higher sensitivity for finding acute MIs. So in 27 of 29 patients who would later diagnose with acute MIs, they found regional wall motion abnormalities with bedside echo. In many of these patients, so only 9 of these patients, did the EKG, the initial EKG, show acute MI. So the bedside ultrasound was able to find the diagnosis of acute myocardial infarction at a much more quick and effective rate than just using initial EKG. And then finally, 13 of those 29 later did develop pathological Q waves, so the ultrasound was just able to find it more quickly. And then among those who did not have regional wall motion abnormalities, only 2, that's 2.2% of all the patients, were then later ruled in for an NSTEMI by cardiac enzymes. So that also goes to show that in conjunction, the bedside ultrasound allows us to find evidence of myocardial infarction quickly and safely in conjunction with our standard of care. As far as regional wall abnormalities that may be chronic, it's important to look at the normal wall thickness and normal reflectivity, as a thin akinetic reflective segment can suggest chronicity. And so if it's a thick wall that's not moving, start thinking this might be acute MI, as opposed to a thin wall that might have had ischemic changes over time. Using bedside ultrasound for acute MI is a lecture in its own, but definitely a worthy addition to the emergency department practice. As far as STEMI criteria, classically in men greater than 40 years old, we think of a 2 millimeter ST segment elevation in V2 and V3, and 1 millimeter in all other leads. If they're less than 40, it just bumps to 2.5 millimeters. In women, anything greater than 1.5 millimeters in those same anterior leads, and then 1 millimeter in all the other leads is diagnostic of STEMI and should activate the cath lab. And then we'll go over the different findings you'll need in posterior and left bundle branch to then also make those same criteria for cath lab. So a little EKG review. I'm going to give you a second to take a look at the EKG here, and bear in mind as you're looking at the EKG, think about what part of the heart you might see being hypokinetic on the ultrasound image provided on the right. Again, that's parasternal short axis view, and then what vessel might be occluded. So this is a STEMI in the anterior leads. It's showing elevations in V2 and V4, and again, with that information, then also look at where you'd see the anterior wall segment on that parasternal short axis, and we'll see hypokinesis, and start really thinking these things together as I think EKG, I think ultrasound, and vice versa. Take a moment to take a look at the EKG strip. Very good. This is a septal MI. It has the ST segment elevations in V1 through V3, and T wave inversions as well as Q waves that later develop and are in this EKG in V1 through V3. Specifically, that's going to be your septal branch that is occluded. Next EKG here. So this is a lateral STEMI, and it has ST segment elevations in lead 1, AVL, V5, and V6, and depressions in the inferior leads. If you look over at 2, 3, and AVF, you'll see those depressions there. And this is an occlusion of your circumflex artery. So if you see in the yellow on the ultrasound finding, you'll see the hypokinesis there. This is an anterior lateral STEMI. You'll see the elevations in 1 and AVL as well as 2 through 6 on your precordial leads. And this is a laceration of, an occlusion of your LAD and circumflex. Take a moment. So this is an inferior MI. You'll see ST elevation in 1 AVL, and then your anterior lead, or your precordial leads 2 through 6. And that is going to be an occlusion of your RCA. So in the red on your ultrasound image there, you'll see the hypokinesis. This is a posterior MI, also known as an inferior lateral, and it's going to have your ST segment elevations in 1 AVL, and then you'll see those depressions initially in 2 through 6. Your RCA, so you see those depressions in the upright T wave. That's kind of your hint right there, mostly in V2, V3. Again, it's an occlusion of your RCA, about 90% of patients, and then in 10% of patients, it's your LCA. To really help us diagnose a posterior MI, you really want to go for your posterior leads. So you place your typical precordial leads of V4, 5, and 6, and put them on the posterior left side of your patient below the scapula as the diagram shows, and they are now V7, V8, and V9. And now you can see those elevations in those same leads. And this is, again, a posterior MI. And take a look here. Nice little circle. So this is our left bundle branch block that's positive for our Scarborough criteria. You're going to see your STL segment elevations in 1 AVL and V2, V6, but it's difficult to see at first because you have that left bundle branch overlaying those same leads that make a difficult EKG to read. Generally speaking, according to the 2013 AHA guidelines, a new left bundle branch block alone is no longer STEMI criteria for cath lab. If they are hemodynamically unstable or if they have new heart failure in this new left bundle branch block, you should be discussing possibility for PCI or fibrinolytics with the cardiologist, but generally speaking, what is used are modified Scarborough criteria for looking for an MI on top of that left bundle. And so, again, the modified Scarborough criteria are an increase of 1 millimeter concordant ST elevation in 1 or greater than 1 lead, or concordant ST segment depression in V1 through V3, or 1 greater than 1 lead anywhere with a 1 or greater ST segment elevation, and proportionately excessive discordant ST segment elevation as defined by 25% of the depth of the preceding S wave. So on this EKG, if you look at V2, V3, you'll see ST segment elevations with that discordant drop in your in your left bundle on that same side, and that's positive for a Scarborough criteria MI. So what if someone doesn't have an obvious STEMI and it wasn't obvious to send straight to the cath lab? So they have this chest pain and you want to be able to send them home or appropriately triage them for further workup. So in these patients, here at the University of Utah, we implement what's called the HART pathway for early discharge and acute chest pain. The HART pathway is the same as our typical HART score, except it adds the additional troponin testing at hour 0, and then again at hour 3 for a delta troponin score. Generally speaking, you have your patient come in, they have acute chest pain, we put them through the HART score, they're determined to be either low risk or high risk, and I'll go over in a second what that means. And then they'll be subjected to serial troponins. Should those be negative, they're okay for discharge, again, in the low risk patient. However, if the serial troponins in the low risk patient are positive, we could look to cardiology for consult and admission, where we'll get either stress testing or cardiac imaging. If it's a high risk patient, serial troponins again, and if those are positive, same through cardiology. If negative, they still need to be admitted for OBS or inpatient status, as they are a high risk patient. So how do we do a HART pathway and a HART score? So I think it's very helpful to, again, go back and MD Calc. It's an app you can get on your phone. I'm sure, or I assume you guys are already using it, or a similar kind of app to do these calculations, but MD Calc is a great resource. So it's indicated to use on any patient that's older than 21 who presents with any sort of chest pain. And then again, if they're not meeting that new STEMI criteria, if they have STEMI criteria, it's a different pathway altogether, and you're looking at going to the cath lab or using thrombolysis. But so again, chest pain, someone stable and older than 21, this is a great tool to use. So there's 5 components: history, EKG, age, risk factors, and initial troponin. I'll go through those individually. So with history, you want to rate it as either slightly suspicious, moderately, or highly suspicious. The components of the history, and this is a little bit subjective, but if it's retrosternal, if there's pressure, radiation to the jaw, left shoulder, duration that lasts 5 to 15 minutes, if it's initiated by exercise, if they have diaphoresis, nausea, vomiting, if the nitrates were helpful, these are all kind of high risk features. And if they have several of those, or even just a couple of those, you can bump them into the highly suspicious category. If they have maybe one of those and it's kind of vague, maybe put them more into moderate. Or if they have really just low risk features. So again, as I talked about in the beginning of the presentation, if it's localized, sharp, non-exertional, or reproducible with palpation, that's less likely to be ACS. But this is the most objective part of the HART score. EKG, as we just went over, again, if it has a STEMI criteria, doesn't belong here. That's another thing altogether. However, you get 1 point here if you have no ST depression, but you do have a left bundle branch block or evidence of LVH. Or you get 2 points if you have ST segment depression or elevation that's not due to left bundle LVH or attributable to a digoxin. And then there's points based on score, pretty straightforward. If you're younger, it's 0 points, 45 to 64, 1 point, greater than 65, 2 points. And then risk factors. So classically, when we think of ACS, this is a very similar list. So you have hypertension, hyperlipidemia, diabetes, if they're obese, if they're a smoker, either current or if they only quit quit within the last 3 months. If they have a positive family history of cardiovascular disease before the age of 65, or if they've had previous MIs, CABGs, or peripheral artery disease, those are all risk factors. You just add those up. 1 to 2 is 1 point, greater than 3 or greater is 2 points. And then we use our initial troponins, just compare those to whatever upper limits your lab has set up and give a score accordingly. So it'll spit you out a score at the end. The patient we did here ended up having 5. So that gives them a 12 to 65% risk of having a major cardiac event in 30 days. So that's not negligible. So that patient is going down our pathway into cardiology consultation and admission, and will likely need to get either stress test or a cath. And that's really determined by cardiology. But really the cutoff here is at 4. And as you can see here, they've correlated in their study the risk of a kind of cardiac event at 30 days to each of these scores, and then give the recommendations. So it's a really good guideline, but emphasis on guideline, as the authors really emphasize that clinical gestalt should not be trumped by heart pathway. While the heart pathway may tell you this patient's low risk, but if your gut is honestly telling you something different, listen to your own clinical gestalt and follow that. But for a lot of these patients, the heart pathway is very appropriate. So the data behind the heart pathway, this was a paper put out in 2015 by Dr. Mailer. They looked at using the heart pathway compared to just our usual standard of care, where many low-risk patients were either getting stress testing or catheterization, regardless of kind of what their risk factors may have been or what their initial or delta troponins may have been. So if you look here, this is length of stay, and particularly in graph B, you're looking at in the slightly hashed line, the low-risk patients have a much decreased length of stay compared to usual care, and then the high-risk patients then were staying longer, which was much more appropriate. Overall, using the heart pathway resulted in an early discharge rate of approximately 40%, and then it cut the median length of stay by 12 hours. And so for a resource allocation standpoint from an emergency department, this is huge and very helpful, and helps us give evidence that we can send patients home safely and effectively who are presenting with chest pain. Among their patients who were identified for early discharge, they had no revisits for the emergency department that were later diagnosed with a major coronary event within 30 days. So it was a very, very effective pathway to use. As far as treatment, so really, if someone comes with a STEMI or NSTEMI, looking to do PCI within 90 minutes, or thrombolysis, if it looks like they cannot receive treatment within 120 minutes, is really the gold standard. Fibrolytic therapy, if given within 3 hours, results in greater than 30 lives saved per 1,000 patients. And among those, you have a risk of intracranial hemorrhage of 0.5 to 1%. And there's a very long list of indications, contraindications that are suitable for another lecture. But really, if PCI is not available, it's within that 3-hour window, fibrolytic therapy, generally speaking, is very helpful. As far as other adjunctive therapies, aspirin is the only therapy that really also decreases mortality. It's been shown to reduce death from myocardial infarction from 12.5% to 6.4%. So any patient who presents really with chest pain should have 325 milligrams of chewable aspirin given basically when they walk through the door. And then again, as you're all very well aware, nitroglycerin helps pain, and we don't want to give it if someone has a right ventricular MI, or if they're on phosphodiesterase inhibitors such as sildenafil. as that can really drop their preload and make things worse for the patient. Morphine for pain, again, kind of avoid using in the hypotensive patient. And then the beta blocker is indicated per cardiology guidelines, and I've written the prescribing doses there. And then finally, oxygen, if they are hypoxic, is important. However, if they are not hypoxic, oxygen is not indicated. In 2015, the AVOID trial found that you get a larger infarct size and more recurrence for arrhythmia in STEMI patients who were given oxygen, but they were not actually hypoxic prior to the administration of oxygen. So to really kind of make the burden from reperfusion injury less, really reserve oxygen for patients who are indeed hypoxic. Additional therapies, so we have antiplatelet and anticoagulation. Antiplatelet is now also the gold standard. In the CURE trial, clopidogrel was found to decrease cardiovascular death, MI, or stroke by 9.3 to 11.5%. And increasingly, ticagrelor is being found to reduce mortality even more than clopidogrel. And our institution, our cardiologists are recommending ticagrelor at an increasing rate, and the dosing is there as well. In regards to anticoagulation, heparin is required after thrombolysis. It helps prevent the rethrombosis since all thrombolytics are very short acting. So really, if you have a patient who is likely to undergo PCI or CABG within 24 admissions, or 24 hours of admission, or in the setting of renal failure, you really want to reach for heparin. They've put the dosing there. However, if it's a patient who is high risk unstable angina, or even if they're moderate risk unstable angina, or if they're in STEMI, and they're not likely to go for CABG within 24 hours, low molecular weight heparins or enoxaparin is our AHA recommended medication. Generally speaking, it's safer than heparin. And then, as shown in the Essence trial, these medications have shown to decrease death by 20% compared to no medication whatsoever. All right, so that was a breeze through ACS. Here's the references. This is really broad and touched on many different subjects, each of which can definitely be its own lecture. I find WikiEM, Life in the Fast Lane, weekly EKG to be very helpful in rounding out your education in regards to ACS, but I hope this is indeed helpful, and thank you for listening.